All right. Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have a very special guest, Dr. Crystal Jacovino. Welcome to the podcast.
Thank you. It's a wonderful day to be here.
Yeah, I really love your background, by the way. So tell me a little bit about who you are and what you do.
Sure. So I'm board certified in internal medicine and endocrinology. I'm a fellow of the Academy of Clinical Endocrinology, and I currently work online at a company called Henry Meds or Colchis Medical. And we do a lot of obesity management, weight loss, HRT, TRT for men, erectile dysfunction, many other endocrine issues. But the thing that I want to talk to you about today is perimenopause and menopause.
Awesome. So how did you get into did you always love endocrinology, like hormones, or and how'd you get into that?
Yeah, so I really enjoyed treating weight loss and diabetes, especially when I was in residency. I spent about 2 years working in the emergency room after sort of residency, and I didn't like people having very bad conditions. I didn't like seeing people pass away. And endocrinology is kind of one of those fields where like people can get better. Like you can, prescribe insulin, you can prescribe a medication, and people can do better and turn themselves around. And so it's one of the kind of nice like lifestyle medicine, versus regular medicine, and you kind of come together. You can really help people's lives. And it was kind of a exciting merging of experiences that I really liked.
Yeah, I definitely agree. I think it's a very rewarding discipline. And certainly now, obviously, it's becoming, even more important. And thank God we're changing things. So that's awesome. And clearly, you and where you're working is definitely changing things as well. So, like you said, you wanted to talk about like perimenopause and menopause. And it's been a hot topic of conversation lately, but I don't think it's like an ever-ending conversation. So, what is your, I guess, favorite aspect of that from like being an endocrinologist? How would you like to begin the discussion on that?
Sure. So, as an endocrinologist, our job is to optimize hormones, and we're trying not to to pathologize a natural condition, but there are some ways within perimenopause and menopause that our patients are not living to their healthiest life. They're not optimizing their condition. And by intervening with either medication or lifestyle modifications, we can help them prevent just the distress of perimenopause and menopause so that they can live their full life. If you aren't able to exercise, if you're not able to get up in the morning and help get your children ready for school without yelling their heads off, and now you're upset and now you stress eat a bowl of cereal, sugary cereal, like you're not set up well for the day. So I love the fact within perimenopause and menopause we can tweak hormones just a little bit and optimize them so that our patients could live their best lives so that they can do the things that they need to do.
Yeah, I love that. What's interesting is you're using this term or phrase, optimizing hormones. And sometimes we're hearing that a lot, and maybe it's a marketing claim, but it definitely draws patients in. They're just like, what is this? So, what does that mean to like optimize hormones? What hormones exactly are we talking about? And I don't know, how do you go from there?
Well, I'll give the example in perimenopause. So it's often thought that you just, especially, even just a few years ago, when people were having perimenopause, as long as they were still having periods, that they were okay. Or you just give full dose, either birth control or full dose HRT, and there's really no in between. And now we know that we can go ahead and support estrogen, especially if they're having vasomotor symptoms, meaning like the night sweats, and the classic menopausal symptoms. You support menopause throughout the entire cycle, but you might only hold the progesterone in what we call a cyclical or sequential way towards the end of the cycle, which mimics someone's natural hormonal cycle. And you can use that, what we call sequential or cyclical progesterone, throughout perimenopause to support the hormones where they need it. Additionally, we can plus or minus in some women utilize testosterone. as we age, our estrogen and progesterone, they go up and down in different ways. And sometimes you can have high estrogen, sometimes you can have low progesterone, and vice versa. And there's really no good way to figure it out in perimenopause. But one of the things we can count on is testosterone will go down in a kind of a stepwise way. And so, depending on the level, that testosterone can be replaced.
Yeah, I like to think of perimenopause as like a roller coaster of hormones because, like, no matter where you are and doing lab testing, you never know exactly
Right.
what's going to come in. So that's why you have to maybe either do it several times or really realize that it's maybe not about the labs exactly. But yeah, that's a interesting. You already brought up testosterone, which is obviously one of the other hormones that is, pretty important with certain side effects that occur in, perimenopause and menopause, like. So I just didn't know if you wanted to elaborate on that a little bit, because I think one of the other things that you brought up was talking about maybe body composition. So I wanted to see what you wanted to say about that.
Oh, yeah. So as your estrogen goes down, your body will start to store its fat, its visceral fat into like abdominal fat. So it's not just a matter of calories in, calories out at that point. You actually
Mhm.
store fat differently because of the way your body responds to the different levels of estrogen. And so, what I find in a lot of my women, and what we have found in a lot of studies about body composition, is that if we early on help support the estrogen, and then, of course, support the progesterone kind of on the back end, whether they have a uterus or not, we can help shift that storage shifting that's happening from visceral adiposity to abdominal adiposity. And that abdominal adiposity is the thing that's really bad, right? Those are the things that cause
Mhm.
disease. Those are the things that, that is the bad fat. And we can help prevent that if we help support the estrogen early on.
Yeah, sometimes I like to make the comparison, like prior to perimenopause, that the female body was created to like house, I mean, initially house a baby, right? So they didn't want fat storage in that area, right? So men, unfortunately, for them, they can gain that belly fat in earlier age or throughout their whole life. But after, perimenopause and menopause for women, we still slowly get to that shift where we're able to accumulate the fat in that area when previously it was like, I don't know, maybe God made it so that we'd have room for the baby. I don't know. But so yeah, like you mentioned visceral fat. So can you explain that a little bit more? Because that's the fat that we're talking about that's in the abdomen that causes the problem. So why is it so problematic?
Right. And so that is the type of fat that can cause type 2 diabetes. That's the one that's associated with insulin resistance, and that's the one that's associated with heart disease. So that it truly is a worse fat. It's harder to lose. You can't exercise that off. And so this shift in the storage of fat is also accompanied by lower muscle mass too. So
Mhm.
not only do you have a slower metabolism, to try to get off this visceral fat, like you can develop something what we call sarcopenia, or loss of muscle mass. So it's the combination of the two that could really put people in a bad situation where they can't get off this fat, and they have a higher risk of what we call adiposity related comorbidities, or as you guys might typically know, type 2 diabetes, heart disease,
Mhm.
everything bad that could happen because of belly fat.
hmm Yeah, I think some people also describe that visceral fat as like inflammatory, right? I mean, both types give off certain inflammatory markers, but I think the visceral one is known to do that a little more. And I think a lot of people are always trying to, another marketing term, like hearing buzzwords, right? Inflammation, trying to get my inflammation down, eating an anti-inflammatory diet. And that's usually because you want to target that kind of fat that causes these issues. Would you agree?
Yes, yes. And back in my academic career, I actually did a lot of studies looking at inflammatory factors within different types of diets. And one of the co-founders that we used to have in a lot of our studies was perimenopause versus menopausal women. And oftentimes the inflammatory factors were so high in our perimenopausal and menopausal women, that it overcame whatever dietary intervention that we tried. Ultimately, we were looking at a lower carb diet versus a just a traditional standard American diet. And in the true premenopausal women, we were able to lower inflammatory factors just by diet alone, utilizing a low carb diet. But we couldn't do that with diet alone in perimenopausal and menopausal and older women.
Very interesting. And also, like cholesterol markers tend to get worse as well in perimenopause, right?
Yes, yes, they
Mhm.
do. And that often is a sign of the insulin resistance
Mhm.
starting to happen. And so oftentimes I do tell my patients that this may be a time that we may need to start medication, but this is also a really good time to start the lifestyle modifications of increased strength training. So one of the big things that you can do at this time in your life from a lifestyle perspective is increasing your strength training. So resistance training supports like lean muscle, not only lean muscle, but bone health, and it helps preserve muscle, manage appetite, and it will help preserve the same premenopausal metabolism that you have. Unfortunately, at perimenopausal and menopause, you can wind up reducing your metabolism almost by 500 calories a day. So one of the biggest things people come to my practice are is they say, I'm doing the same things I normally do. I'm utilizing cardio for my exercise. I'm eating the same amount of calories, but the pounds are just piling on. I have to say, stop. Your metabolism is much less than what it was just a few years ago. So you either need to eat less or we need to boost your metabolism by adding some strength training, plus or minus adding in the hormones. And most of the time, we're able to turn things around by adjusting their diet, their exercise, and potentially adding hormones if necessary.
Yeah, I'm glad you brought up the metabolism again, because I was going to ask you, how would you explain that there's this reduction in metabolism or presumed reduction in metabolism in menopause?
Well, and we see it. We put these
Mm,
people in either DEXA scans, we do their body compositions. We can see that their basal metabolic rate is lower as they age. And a lot of times that is because of the loss of lean muscle mass. Women, especially women my age, in your 40s and 50s, we don't prioritize strength training. It wasn't, remember when we were growing up in the 80s and 90s, people were afraid of bulking up. So not as
mhm.
many people are strength training. They go to the gym, they spend 45 minutes on a treadmill or an elliptical, and they're not prioritizing strength training. We have a lot of different things that are going on in our lives. We have work, we have kids, we have parents, and they think that they don't have time or the energy for strength training. And that's just not true. And strength training is one of the biggest things you can do to help turn around that metabolism. Sorry, I got on my little soapbox about strength training, but yes, we
Oh,
do.
I'm always on a
Okay.
soapbox about strength training. I certainly welcome it. I mean, yeah, I mean, these are the same things that I tell my patients. So in our office, we do a resting metabolic rate test, like, measuring the exhaled carbon dioxide, and then we do the body composition as well. And it's really wonderful to see when they have improvements. But clearly, yeah, as per this conversation, perimenopause with the way that the fat shifts, the way that metabolism goes down because of the lack of, lean muscle, it can make a big difference of why the patient is unable to eat as much as they're doing all the same things and still struggling, right? So it's wonderful that we're now getting this advice and education to be able to treat the things that could be causing it, like you mentioned, balancing those hormones and giving that estrogen back. But how would you full testosterone in this situation?
Okay. So generally, just because of, order of operations, I will, if a patient comes to me and they're having vasomotor symptoms, estrogenic symptoms, fatigue, excess like PMSE symptoms in a perimenopausal state, I generally will try to get the estrogen and progesterone only necessary if they still have a uterus, kind of optimized first. So I may do that first, see how symptomatically they're doing. If they choose to do labs, I don't always need labs. Will try to make sure that they are in a comfortable place for their estrogen. And then what I do typically then is I'll get labs for testosterone, just because for safety wise, with compounded testosterone, which is the type I use, there could be very high excursions of testosterone depending on how you're using it. So I don't always say you need labs for perimenopause and menopausal care for estrogen, progesterone. For testosterone, I do. So we'll get labs, and then I use a version of compounded testosterone that's 0.05%, and we use 1 or 2 clicks depending on what we believe is necessary and depending on symptoms to the inner thigh up to every day, sometimes just twice a week, and we kind of just try to keep the levels lower than 30 to closer to 70, at least in my practice is what I see seems to help. Besides just not having to deal with 3 hormones at one time, which is very difficult, sometimes I like to optimize estrogen and progesterone first because sometimes the same complaints that people have in terms of like libido and fatigue are often helped with just the progesterone alone. And so then I'm able to use much less testosterone to get the same symptomatic relief. Because you always use the least dose of everything possible for the least amount of time for symptom control. So I also like to listen to the patient. And a lot of times, they're complaining very specifically libido issues. They're complaining of muscle weakness. They're complaining of very specific testosterone symptoms. So I try to very quickly get that estrogen, progesterone where it needs to be so I can get them to the testosterone.
Yeah, no, I agree. Typically, you want to optimize estrogen first because it's the, main one, and then kind of add in. It's best to do them one by one. I agree. Like how you do that approach. I think that's nice. Do you ever use testosterone just for like, I guess, improving the lean muscle mass?
I haven't yet in a lot of my patients, just because oftentimes if they come to me talking about sarcopenia and obesity, sometimes we'll consider, like, I know we're not talking about it today, but we'll talk about GLP-1s, we'll talk about other weight loss strategies within lifestyle modification. So I haven't had a patient where testosterone monotherapy was the answer for lean muscle, but I do have a lot of patients that I will utilize testosterone monotherapy for what we call HSDD, or hyposexual desire disorder. And these are premenopausal women where I'll utilize low doses of testosterone for libido and desire, even if they're having great menstrual cycles, even if all their other hormones are normal.
Yeah, I mean, I haven't obviously used that either, but I think that, I mean, what I asked with the testosterone alone, because that's not usually the only goal, right, for a female person
Right, right,
anyway. So
right,
that's not what
right.
they're asking, right? So typically, we want to address the patient's needs and what their, pain points are. And it's not like, hey, I want to be the leanest, whatever. But, and like you said, most people aren't even doing enough resistance training in the first place or could do more. But yeah, that's clearly a place to focus on first anyway. Yeah.
Yeah, yeah. And I definitely have some patients that do talk about, their spare tire, and they're what we call this, like, not like they're lean, but they're not fit. And sometimes in those patients, they have a lot of other metabolic issues anyway, lots of risk for type 2 diabetes, or they have heart disease in their family. And so I may be optimizing their hormones in an HRT way, but I'm also in the metabolism and weight loss management category, potentially working on some other things too, and whether they qualify for something like a GLP-1 or not, or we're just working with lifestyle modifications.
Yeah. What are some of the biggest myths that you kind of hear from patients about menopausal weight gain?
Sure. So patients come into my office, or my online office now, and they are so worried because their family members have breast cancer. And that's probably the biggest thing, is they are so scared because they've had an aunt, they've had a cousin, they've had a family member with breast cancer. But we even have studies now where even women with BRCA1, BRCA2, so these are the most increased risk of breast cancer you can get, and they still were able to utilize some amount of hormones for their HRT journey in a very safe and effective way. In this particular study, these women happened to have a oophorectomy, meaning they had their ovaries removed. But in those women, they had the same risk as a patient without a BRCA gene. So I always try to tell my patients that even the most risky patients can utilize some form of HRT. And whether that means we're using a transdermal version, maybe we're just using vaginal only so that there's no systemic absorption. Maybe we're only using a certain amount for a very short amount of time in their lives. Maybe we're making sure we're up to date on their mammograms, that we're doing breast exams. Maybe we're looking at how many people in their family have had breast cancer. We have to individualize that risk for everyone, but probably that's the biggest thing that my patients are worried about is I don't want to get cancer from this. And
Mhm.
you know as much as I do, that's the because of that stupid WHI study that, erroneously showed that there was some increased risk in breast cancer and heart disease 20 years ago when they were using giant horse pills of estrogen in basically everyone. And it didn't matter if you had gone through menopause 10 years ago or if you were 80 years old, they were giving you pills of synthetic estrogen and progesterone. In those patients, yeah, that is not a good candidate for HRT. That is not a good candidate for oral pills most of the time. And we wouldn't do that nowadays. Right now, we're all about individualizing your risk, your dose, and then your time on hormones. And we can make it so that we don't increase your risk of breast cancer. So sorry, that was a very long answer to that, but that's kind of my spiel that I give to patients who are
Mhm.
concerned about breast cancer.
Yeah, no, I mean that's super important. I guess I don't know what to say is, but the where the reservation, I guess, for the patient to want to do any sort of hormonal therapy, they, learned that study. Oh my gosh, everything is, forget it out the window. And we're going to get breast cancer if we use hormones. So when that happened, it was such a disservice to everybody. But I think currently, I think we're in the right direction with everything. So it's important to dispel that myth. But there are, cases where it might be not a best thing, but it's still maybe it's a shared decision between the patient and the person prescribing it. Yeah.
Yeah, and so the WHI study actually has still been going on, and they were
Mhm.
able to very recently update their data, and it's the basis of the Menopause Society guidelines. And
Mhm.
estrogen, in and of itself, actually doesn't cause any sort of increased risk of breast cancer. Now, if you pair oral estrogen plus oral progesterone, in patients that are higher risk, there is a slightly higher risk of breast cancer in those patients. And so I would, in those patients, sometimes advise them, maybe we're not going to use an oral pill. Maybe we're going to use a transdermal. Maybe we're going to use this for a shorter period of time. Maybe we're going to use a compounded cream that is giving estrogen at a lower dose, also known as maybe bioidentical, as compared to maybe like a commercial oral pill. I may use a patch. So lots of things are on the table.
Yeah, so you bring bioidentical. I was just talking about this with the patient. Why don't you dispel the confusion around that?
Sure. So it's all estrogen. It's all progesterone. With bioidentical, I can make it like a 50-50 mix of like estriol and estradiol. And estriol is the pregnancy hormone. With progesterone, I can use like a permetrium instead of like methoxyprogesterone. But ultimately, it's all the same. The reason why I might choose a bioidentical in some patients compared to a commercial product is honestly because I'm trying to nail a dose that may not be commercially available. Not everyone fits into the little boxes of like these patches or these pills, and some people want to use the lowest possible dose. So in those cases, compounded meds sometimes, or bioidentical meds. I don't love that term because it's not a real term, but compounded meds sometimes are the answer for those patients compared to what is the commercial dosing. But in reality, there is commercial dosing for progesterone of permetrium as well as medroxyprogesterone. There is estradiol out there as well as other forms of estrogen. It's all about what works for the patient.
Mhm.
And I have some patients that are so fearful of starting estrogen that I want to start them on an itty bitty, itty tiny dose. And in those cases, bioidentical or compounded is a perfectly legitimate and safe way to titrate up sort of little bit by little bit. And actually, I was about to show you, we're able to, with our compounded meds, utilize, clicks, kind of little by little if necessary. But in
Mhm.
reality, if you look at the studies, there's really no difference. Is that what you see with your practice too?
Well, yeah, no, I normally say that the bioidentical is, basically most of the FDA approved medicines are bioidentical. So
They, yeah, I
they're
don't love
not the
the word.
horse equine pill, or whatever. So they are the ones that are already available. They're just using a marketing term to make people, feel better. Like this is identical to the hormone that your body produces, but yes. Yeah,
It,
so some
yes,
people.
they're the same thing.
Mhm. Yeah.
It's you can compound with like a couple of different things in it, like if you wanted to, but it's not necessary. The only
Mhm.
thing that really bioidentical, and again, I hate that term, compounded does that commercial doesn't is it doesn't pigeonhole you into a certain
Dosing.
dosing.
Yeah.
That's it.
Yeah.
Otherwise, commercial is absolutely fine, and it's really convenient too, especially if you're talking about things
Mhm.
like patches.
Yeah, I mean, typically it's usually a little bit cheaper for the patient too. So sometimes even covered by insurance. So those are important things that I try to stress as well. But yeah, that's super, super helpful. So what else did you want to discuss on this topic so I don't lead you astray to a different way?
Oh, I was just going to talk a little bit about sleep disturbances. A
Good.
lot of women you can get vasomotor symptoms up to 10 years prior to the start of official menopause. And it sneaks up on women. Like they don't really know, like, why am I getting up at 1:45 at night? Why am I getting up at 4 in the morning? Because it's not a true, you're not soaking the sheets. And in reality, this sleep optimization is very affected by estrogen levels, but also over time, if you plot it, your melatonin levels actually decrease too. And
Mm.
so this is not like a thing like you have to then take melatonin supplementation, but it's this idea of like sleep optimization and stress management can reduce this idea of like visceral fat, but just also from a very practical standpoint, if you're waking up multiple times a night, you're not going to want to get up at 5 in the morning to go exercise. You're not going to want to make healthy foods for your kids and you later on throughout the day, you're going to pull over and get fast food. And it's because you're tired. And so my point to sleep optimization is like sometimes it's really subtle. You're not always just like, what they show on TV where it's like you wake up in the middle of the night covered in sweat. It's like sometimes it's like this like subtle, like I'm just not sleeping throughout the night. I am waking up more. I'm having more restless leg. I'm having more, nighttime awakenings that have nothing to do with like urinary issues. And so sometimes I'm like, that could be perimenopause. Let's go ahead and treat because it's safe and see how that helps, assuming, you don't have sleep apnea or other things that could be causing those
Mhm.
sleep
Mhm.
issues. But sometimes I find that just getting people their good sleep, I don't even have to use hormones then. Sometimes if we're able to sleep optimize, they're able to do the things that they need to do lifestyle wise to get back on track. And I love that for them. There's nothing better that I can prescribe than a good 6 to 8 hours of sleep at
Oh
night.
yeah.
We, as this in between sandwich generation, oftentimes don't get.
Yeah, so you mentioned, well, vasomotor symptoms, just to clarify, that's usually what we call about like the hot flashes,
Yeah,
right, for
hot
everybody.
flushes,
Okay.
but
Yeah, and that can wake people up. And then, I mean, you mentioned just in general, like maybe it's not the hot flash waking you up, but it could be something else, right? And so sometimes I think like anxiety and stress is obviously interplaying that. And we know that perimenopause, menopause can increase both of those. So that could be another reason you're waking up, right? And then I did not know about the melatonin decrease. So that's very interesting.
yeah,
Yeah.
yeah. I have a cool chart. I can provide it for you too, but it shows
Mhm.
how estrogen, will go down as well as testosterone, and then it has melatonin. It's not as steep of a curve as
Yeah.
testosterone is, and there's really no evidence to like support supplementing it, but I
Mhm.
have found just in general optimizing sleep then really does help. And in my practice, I talk about more like CBT type ways where we go through that first before we work on any sort of
Mhm.
medications.
Yeah, well, that's a really, I think, nice approach. I mean, a lot of times I think if you're already supplementing with estrogen and adding the progesterone, sometimes just doing the progesterone every day instead of in the cyclical pattern that you mentioned, I think that can help some patients too.
Oh,
Yeah.
a progesterone pill at night is really nice for
Mhm.
sleep. It makes you really sleepy. So sometimes that helps in and of itself.
Yeah. And then obviously with what we're discussing, like the sleep weight connection, right? Super important. Like you said, you're not going to, if you're sleeping well, you're less likely to go to the fast food. You're less like or more likely to do some meal prepping and paying and making good choices, really, because it's hopefully not as hard to do those things when you have rest, right? So it's super
Right.
important. And I think that's great. And you made another good point about like getting up to work out, like who's going to get up early to work out if you didn't sleep at all, right?
You'd be catching up on your sleep. You are not going to be getting up to work out.
Yeah. Yeah. Well, yeah. So sleep is super important. So I think that's an excellent addition to the conversation. Is there anything else that you can think of that is really a hot topic right now? Or do you have a good patient case to share where someone just, started doing a lot better or a win?
Yes, yes. I actually just had a win the other day. It was a patient who I had been seeing for GLP-1 weight loss therapy. She had come in wanting to do, I think, phentermine. Like that was she
Mhm.
came to me asking for phentermine. I said, no, 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 let's her metabolic was much better for semaglutide. We wound up doing semaglutide on her. She had lost weight, but she was still complaining of issues with this visceral adiposity. She was complaining she was tired all the time. And she had just got that really like, she had gotten that look to her that you see a lot with our semaglutide or, tirzepatide patients where, sometimes they get the sunken in cheeks and like, I had talked about strength training, but maybe I didn't talk about it good enough because I was so worried about other metabolism issues with her.
Mhm.
And so we had finally gotten to a point where I was like, listen, your BMI is like 22. I am so proud of you. But I'm looking at you and you're complaining of it too, this visceral fat, you're still complaining that your arms are all flappy and your skin laxity, you're complaining of fatigue. You should be living your best life, right? You had just lost 35 pounds on semaglutide. You're doing amazing. What else is going on? And so we wound up actually not even choosing to do labs with her. The Menopause Society doesn't recommend labs unless some sort of special scenario. And so I said I was just going to treat on symptoms alone. We did a low dose, I believe, an estrogen patch. And then we did sequential or cyclical progesterone with her. And in just 2 months, she came back feeling like $1 million. We hadn't got to testosterone yet with her, but she says that she now can move her body in ways that she couldn't before, right? Because she had the obesity before. And so now she's getting to the gym. She's utilizing resistance bands. She's utilizing therapies that are helping her. And she just says she feels energized in a way she hasn't before. And there are so many factors there. She's able to sleep throughout the night. She's able to wake up and she's exercising, and just exercising alone, right, makes you want to feel better and it just makes you feel energized. She was already making better choices for food because of having the semaglutide on board. So I'm just very excited for her. She had never even known that sequential progesterone was an option. And she was one that was super scared of using too many hormones. And I was like, listen, you're not even using hormones the entire part of your cycle. And I'm so proud of her. I'm so proud of what she's done. And I'm so proud of us as providers and society where we can help support perimenopausal women in the same way that we're supporting menopausal women. So it was a really
I
good
love that.
experience for her.
Yeah, that is a great, great case. And I would say I've had a lot of patients as well, or maybe a select few, maybe not that many, but are, on a GLP-1 journey. And then, I'm realizing they're at that age as well, where some of these symptoms that they're having could be like perimenopausal or menopausal, and kind of combining that hormonal therapy with their GLP-1 treatment really like kind of gets like a little bit better package where they're getting back to more feeling like themselves. They're able to do these things as well. So it's very similar story and case. So it's so nice to see. And it is an interesting combination of now, combining the GLP-1s with the HRT. So I think it can be very effective for patients too. And then adding in that lifestyle component will allow them to continue on.
Yeah, and not that particular patient, but I've had another patient where this was a true menopausal patient, and she's like, it feels like the lights came on, that she didn't realize how poorly she was doing until
Mhm.
we gave back the hormones. And sometimes it's because you have let it gone for too long, right? You went through
Yeah.
your 40s, you went through your early 50s, and you don't even realize how drained you are. You don't even realize how like much is not in your bucket anymore, and that you need hormonal support. In addition to other support too, you need to
Mhm.
be talking to a therapist. You need to be, making sure that your mental health is on the forefront. Sometimes these things just build up and you don't even realize you're drowning until someone hands you a life preserver.
Yeah. So, Dr. Jacovino, well, do you have anything else you want to share before we wrap up?
I just want to say that there is more and more studies out there where they use DEXA scan, ultrasonography, body composition, and they do show that early use of hormonal interventions can help body composition. I tell my friends this, and I tell my other cheer moms and gymnastics moms, these changes are not inevitable. You do not have to gain 10, 15 pounds in menopause anymore or perimenopause. Just because your mom did, just because your aunt did, we now have the science to show we can help you. And the earlier, the better.
Yes, that's a very good message. The earlier, the better. I love that. Yeah. Okay, so where can people find you if they want to follow you, work with you, or anything like that?
Sure. So if you want to see me, you can just go to henrymeds.com, and there are a variety of ways to see me or any of our other providers. And we would love to see you for HRT or anything else.
Awesome. Well, thank you so much for being a guest on the Get Healthy Tampa Bay podcast. We'll put all your information in the show notes, and everybody stay tuned next week for next week's episode. Thank you, Dr.
Thank
Jacobina.
you.